Most of us are conditioned to think of a sluggish gut as a simple lifestyle failure. If things stop moving, the immediate assumption is that you aren't drinking enough water or you skimped on your daily fiber. But in clinical gastroenterology, chronic constipation is treated as a check engine light. It is an alarm bell pointing to dozens of potential hidden failures that have no relation to your diet. To track down the real culprit, doctors use this specific diagnostic funnel. It is a systematic framework that filters out causes layer by layer, moving from external inputs at the top, down through systemic misfires, anatomical roadblocks, and finally, primary gut disorders. The clinical logic here is strict. A doctor must systematically test and rule out every external factor and organic disease before they can safely confirm that the gut itself is the source of the malfunction. Because the root cause can hide anywhere from the spinal cord to the endocrine system, a generic over-the-counter fix often fails. Identifying the exact point of biological failure requires this rigorous investigation. The first level of the funnel isolates the baseline lifestyle checks. Doctors first look for inadequate fiber and low water intake, as well as the overuse of coffee, tea, or alcohol, which can disrupt colonic transit. Beyond diet, pharmacological causes are a major, often overlooked external input. Many common drugs can inadvertently paralyze the digestive tract as a side effect. This list includes everyday medications like nonsteroidal anti-inflammatory drugs, antidepressants, and calcium channel blockers, as well as lead, iron, or even vitamin D intoxication. If adjusting these external variables doesn't restart the system, the doctor must proceed down the funnel. The persistence of the symptom proves the issue isn't a result of user error. At the second level, we look for systemic misfires. This is where the body's internal control centers, the systems that manage hormones and electrical signals, begin to malfunction. Metabolic and endocrine disorders, specifically diabetes and hypothyroidism, chemically disrupt the body's normal rhythms. When these systems fail, the muscular contractions needed for digestion often slow or stop entirely. Digestion also relies on a clear signal from the nervous system. In many cases, the brain or spinal cord may simply fail to send the correct move signals to the intestine. This breakdown can be caused by neurological disorders, like Parkinson's disease and multiple sclerosis, or muscular diseases, like muscular dystrophy, which prevent the gut from receiving or reacting to the body's instructions. In these scenarios, the gut tissue is healthy. The constipation is a secondary symptom of a much larger breakdown in the body's communication network. If the signals are being sent, but the system remains backed up, doctors must look at the hardware. What happens when the physical plumbing is barricaded? These are anatomic causes, structural roadblocks located within the lower intestine or the anus that physically prevent evacuation. Structural issues like strictures, obstructing tumors, or anal fissures create a physical bottleneck. These obstacles make it impossible for waste to pass, regardless of how well the rest of the system is functioning. Hardware blockages cannot be cleared by adding fiber or taking chemical laxatives. They require direct physical medical intervention to clear the path. Only when every other layer has been cleared do we reach the bottom of the funnel, primary or idiopathic constipation. Idiopathic means that every external, systemic, and physical roadblock has been ruled out. The investigation has finally isolated the gut itself as the inherent source of the malfunction. This is where we differentiate between two ways the colon behaves sluggishly. In normal transit constipation, stool moves through at a standard rate but is difficult to evacuate. In slow transit constipation, the colonic motor activity itself is impaired, dragging the entire process out. If the transit speed is normal but evacuation is still difficult, the issue may be pelvic floor dysfunction. This is where the muscles at the exit fail to coordinate, leading to a feeling of incomplete evacuation even when the plumbing above is working perfectly. Reaching an idiopathic diagnosis is a successful identification of the root cause. It confirms that the problem lies specifically in the colon's motor activity or the pelvic floor muscles, allowing for a targeted treatment plan. The diagnostic path we just followed shows that the cause of a sluggish gut can exist anywhere from a daily vitamin to a spinal cord defect. Relying purely on over-the-counter laxatives without investigating these layers is risky. It treats the symptom as the disease, potentially leaving a systemic or structural failure unaddressed. Chronic constipation is a message from the body. True relief begins not with a quick fix, but by identifying exactly which part of the system is asking for help.